So welcome back, everybody. I hope you all enjoyed the first session as much as I did. It was incredibly informative. So my name's Anna Hume. I'm a microbiologist with Pathology Queensland and also an ID physician at the Royal Brisbane and STARS facilities. And I'm particularly interested in genomics and molecular methods and applying these to antimicrobial resistance and rapid diagnostics. So there are many topics in this next session that are dear to my heart. And the first speaker that we have today in this session is Daniel Yeoh, and he will be presenting on paediatric invasive fungal disease and current diagnostics. He is a paediatrician and infectious diseases physician at Perth Children's Hospital with a clinical and research interest in infections in immunocompromised hosts. He's completed his PhD studies through the University of Melbourne in 2024, focusing on improving diagnostics, optimizing prophylaxis, and exploring novel treatment approaches for invasive fungal infections in children. So please join me in welcoming Daniel to the stage.
Hi, everyone. Thanks for the opportunity to speak. I came over from Perth yesterday, so excuse me, it's sort of almost like an international flight. I'm going to speak about invasive fungal disease in children with a particular focus on pulmonary mold infections and the diagnostics around that, where it can be particularly tricky. So just to set the scene, I think we've looked previously in the Australian context of how common fungal disease is in children. And this was a study led by Julia Clark here, children across Australia between 2003 2014. This is the terrific cohort study. And we found that just under 12% of children with allogeneic stem cell transplant developed fungal infections, and just over half of these were due to mold, with a mix of Aspergillus species and then also non-Aspergillus molds. Importantly, the overall survival at 6 months was only 70%, just below, in children undergoing HSCT who developed a mold infection, in sort of highlighting the impact that this has on survival. More recently, Hannah Walker, one of the transplanters from Royal Children's Hospital, has looked at pulmonary complications in the setting of allogeneic stem cell transplant in Perth, as well as in Melbourne. And this was 250 children who underwent allogeneic stem cell transplant between 2016 and 2022. And just under a half developed pulmonary complications, and most of those were, infectious complications with some overlap with non-infectious complications. Looking at infectious complications in this group, fungal pneumonia was the most common. And importantly, again, overall survival in those who had pulmonary complications was significantly lower compared to those who didn't develop pulmonary complications. And of the deaths sort of attributed to pulmonary complication, fungal infection contributed to at least a quarter of those. So an important cause of morbidity and mortality in the allogeneic stem cell transplant setting in children. I guess that's what leads us to the challenge around diagnosis. We know that these children are often neutropenic for a prolonged period of time, have other immunosuppression going on, and often develop fever, prolonged fever. And the mainstay of diagnosis is really, imaging in the first instance and CT chest imaging. However, there's a little bit of confusion, from a clinical point of view in interpreting these findings and the reports. And that's somewhat reflected in the paediatric literature, which is relatively sparse. So when we've reviewed this, similar to adults, nodules are the most common findings, although they do have a wider differential. And the halo sign, which is more pathognomonic and more, specific for fungal infection, really ranges in terms of prevalence in these studies from 0% up to 100%, depending what you look at. And importantly, a lot of these studies are from older cohorts of children treated 20 years ago, where sort of supportive care and chemotherapy regimens were likely quite different compared with what we do currently, and the numbers overall are relatively small. So in that context, we thought we'd look at our Australian data, both looking at the terrific study between 2003 and 2014, as well as a more recent cohort of children with leukemia across Brisbane, Melbourne and Perth, the study, and that mainly focused on prophylaxis, but we also looked at confirmed pulmonary IFD cases across that cohort. And we grouped them and had 2 individual radiologists review the findings, both looking at the EORTC criteria, which are, a consensus criteria for the diagnosis of pulmonary fungal infection, more for a research context than clinical use, and then also sort of what other findings outside of the EORTC criteria were present. We also looked at the reliability and the agreement between the raters, and then looked to see if there's any difference when comparing Aspergillus infections and non-Aspergillus mold. And that's important because they have quite different treatment regimens. And if you can tell early on, just based on imaging findings, then that can impact on your choice of antifungal agent and surgical intervention. And so overall, we included 99 cases, about 2/3 were Aspergillus and a mix of non-Aspergillus molds, and also histopathologically confirmed culture negative cases as well. The vast majority of children had an underlying hematological malignancy, unsurprising given the cohorts, and around a quarter had undergone stem cell transplant. And what we found was that, similar to the previous literature, nodules were the most common finding, and a halo sign was present in about half of cases. Segmental or wedge-shaped consolidation, which is again one of the EORTC criteria, was present in just over a third. And the more classic signs of primary aspergillosis, particularly cavitation and air crescent sign, were actually relatively rare, again, consistent with the previous literature. Interestingly, when we looked at a variety of other features, we found that there were sort of a range of other findings that were present in this setting of confirmed primary mold infection, including granulosa custody, atelectasis, and effusion. And this is consistent with what the EORTC sort of group saw in predominantly adult literature when they went to revise the definitions, although none of these findings actually they felt were specific enough to include in the research definition. So that remains sort of those previous features. We only had 2 raters in this, but even between the 2 radiologists who looked at it, we found that there was not always perfect agreement in terms of identifying nodules, and particularly for halo sign, which is important because I think that's maybe something that we have in our minds as clinicians as being more specific to invasive mold infection. There was quite a degree of variability and disagreement as to whether there was halo sign present or not. And we're planning to do a bigger assessment with including negative scans and a larger number of radiologists to get a sense of if there is sort of this variability in radiology reporting, because we often rely on the radiology report if we can't get microbiological sampling to decide on starting antifungals or not, and sometimes driving further diagnostics or not. And finally, we compared sort of the findings in Aspergillus and non-Aspergillus molds, and we couldn't find any particular feature, either EORTC defined or those broader range of features, which was predictive of a particular pathogen, and really sort of highlighting that we can't tell what's causing these changes just based on looking at the scan alone. So I think, again, nodules most common, halo sign present about half, but a broad range of findings in this context, with a bit of variability between the 2 radiologists reporting. And I think together this sort of shows us that ideally we should be pushing for microbiological confirmation in these cases to drive our treatment decisions. And so I think this is reflected in the real world where, as you can see with fungal pneumonia, the dark blue represents clinically defined infections. So ones where we don't have microbiological confirmation, and these are children who have CT chest findings in the setting of prolonged fever, where we're not sure, I guess, the EIT classification of possible invasive fungal disease. And when we've looked at this in the Pacific cohort, don't have a slide up, but up to 40% of children didn't have any microbiological testing, and that includes in non-invasive, invasive fungal diagnostics. But despite that, received sort of prolonged antifungals. So a little bit of a tricky space. When we look across the guidelines, really the diagnosis is largely based on respiratory sampling, where this is possible either by bronchoalveolar lavage or lung biopsy using both culture direct microscopy and then galactomannan and Aspergillus PCR, or panfungal PCR for lung biopsy. There's some data suggests that that's useful. However, I think as clinicians, we all know that this is somewhat challenging. Children with respiratory compromise, there's always a risk-benefit analysis of doing a BAL, which may sort of lead to intubation where the child ends up in ICU. And similarly with lung biopsy, these children have suppressed marrows, often thrombocytopenic, and there is a risk of bleeding, and that can be actually catastrophic in these cases. So there's always a bit of a risk-benefit, but I think ideally we should be looking to get microbiological sampling from the respiratory system for these cases. There are sort of non-invasive sampling as used in adults as well. I think the performance of some of these, particularly beta-D-glucan, is poorer in children, and there's a recommendation against use of this as a diagnostic test in this setting. Aspergillus PCR probably performed slightly better, but is not widely available across centres in Australia. And I think galactomannan is widely available and has reasonable sensitivity and specificity, but has some particular challenges. In this systematic review in 2016, looking at paediatric studies assessing the utility and performance of galactomannan as a diagnostic test, sensitivity and specificity were quite high, but the positive predictive value ranged depending on the study. And most studies, it was sort of below the 40% mark. And these authors concluded that perhaps it shouldn't be used as a standalone diagnostic test and should be reserved for children with a higher probability of fungal infection, so prolonged fever, underlying risk factors, as well as imaging changes or other clinical features suggestive of fungal infection. And similarly for PCR, sort of where sensitivity and specificity were lower than for galactomannan, and that's PCR on the blood, they suggested that due to poor positive predictive value that we should be a bit more selective in the use of these tests in children. We are using more mold-active prophylaxis in our high-risk groups, and I think the recent Australian guidelines were recommending this for high-risk ALL patients, AML patients, and then consideration in allogeneic stem cell transplant in the pre-engraftment phase. And certainly with the presence of GVHD, we are recommending anti-mold prophylaxis, and this does have an impact on the performance of galactomannan. And I think in this study, I think it's been shown in adults, but in a couple of paediatric studies, including this one, this was 200 children with 300 at-risk periods, and about a third of those at-risk periods were covered with mold-active prophylaxis. And the sensitivity of galactomannan in that setting for proven probable cases of invasive aspergillosis was 33%, which is lower than sort of the overall without prophylaxis. So I think still a useful test in this setting. There's a high suspicion, but a negative test needs to be taken take I guess the impact of mold-active prophylaxis into consideration. And also importantly, it's a aspergillus specific test, so a negative test doesn't rule out infection caused by another mold. So I think I won't spend too much time on next generation sequencing, because I know Beatrice is going to cover the newer diagnostics, but there is sort of hope on the horizon with sort of cell-free DNA, next generation sequencing, and has been looked at in a couple of cohorts of children. I think in this case, there was 40 children who contributed samples, and of the 6 proven and probable invasive fungal infections, the next generation sequencing had consistent results with the standard microbiological testing in 4 out of the 6 cases, but was negative in 2 out of the 6. Again, a bit of challenge around what is our gold standard, and they question, I guess, the Aspergillus on culture for that particular case. And I think the other point to make is of the children who didn't have invasive fungal infection, next generation sequencing picked up a range of pathogens, including a couple of cases of Candida where the clinical significance is uncertain because the classic microbiological tests were negative. So I think a little way off for this to be I guess, clinically useful test, but certainly sort of promising given the limitations of the currently available diagnostics. And in reviewing this, we've sort of proposed, I guess, a pathway for diagnosis really based on imaging in the first instance, and then if there's imaging changes, just really considering early respiratory sampling along with serum galactomannan to guide sort of further treatment in this space, although still there remains a paucity of evidence as to the best approach and paucity of evidence to guide this as well. So I think just very quickly in terms of what we're moving on to look at, as I said, we're looking at a larger assessment of reliability of radiology reporting, including some negative and possible cases, and not to put our radiologists sort of under the spotlight, but really to sort of help us understand how much we can rely on these radiology reports, and then also assessing how well we're using the microbiology tests and assessing the utility of this equal Aspergillus score, which is a guideline-derived score, really focusing on the diagnosis of suspected primary aspergillosis, as well as the initial treatment, to see if this is predictive of outcome. And then if so, then that may form the gold standard framework for the workup of these cases in children. And in Melbourne, they've had a PET MRI machine that's been used in the assessment of undifferentiated fever or suspected fungal infection. And we're looking at the utility of that as a single sensor. And then finally, using the repository of scans that we've gathered, hoping to explore the utility of machine learning and recognizing these through images as well as reports. Sorry, I had a thank you star that I didn't realize Gab and Julia are in the audience to come up here and just don't thank anyone else because I've done all the work. But certainly there's a lot of other people who contributed to this, so it hasn't come up, and that's a couple of family photos.